Good morning, good afternoon, good evening, or whenever you're viewing this video or PowerPoint. Thank you for taking the time to learn more about our new obstetric protocol for sepsis in SVMH. Attached to this email, you will also find the algorithm in its full form so it's easier for you to see. Also, I've attached the checklist that the nurses will use so that you can also view that. Additionally, I attached a very short, brief 10-question post-assessment evaluation so that we can have some confirmation that this education has been completed, as it is part of our Beta Healthcare Tier 2 collaborative for this year. Dr. Jones and I are part of the Perinatal Collaborative and represent SVMH, and we have been selected to be part of the pilot project. So we are excited to finally get this underway, and we anticipate this will be going live probably in April. So what is sepsis? I'm completely confident that you understand what sepsis is, but in the name of standardization, this is the definition we provided for our nursing staff. Sepsis is a clinical manifestation that can result from trauma, infection, etc., that causes a body-wide activation of immune and inflammatory cascades that can then cause some end organ dysfunction and morbidity or even mortality. So when we look at sepsis, we know that it's also progressive. We go from SIRS to sepsis to severe sepsis to septic shock. The Surviving Sepsis campaign has made some clarification to their definitions, and these are them listed here. So SIRS, Systemic Inflammatory Response Syndrome, applies when there's a temp greater than 38.3 or less than 36, a heart rate greater than 90, respiratory rate greater than 20, etc. And sepsis is then SIRS with a suspected or a confirmed infection. Severe sepsis would be sepsis plus evidence of acute organ dysfunction. And septic shock is severe sepsis with persistent hypotension despite fluid resuscitation, or those that would need a higher level of care to maintain perfusing blood pressure. So maternal sepsis occurs in a seemingly small amount of pregnant women across the country, 0.04% of all deliveries in the United States. But when you look at how that contributes to the overall maternal mortality in the United States, sepsis is attributed in 23% of those. The majority of cases of maternal death from sepsis are likely to have been preventable. And some background on that is those states in the U.S. that have maternal mortality review committees, and just about everybody does now, take every maternal death and they dive very deep and they look at the vital signs, they look at the progress, they look at the orders, they look at the communication, and they identify hinge points that may have contributed to this poor outcome. And then they evaluate if earlier identification, increased communication, or maybe a different treatment could have altered the outcome. And that is where the 63% comes from. And this 63% is California's number. California has a pregnancy-associated mortality review task force that looks into these as well. In addition, for every maternal death that occurs, so 0.04%, there are 50 women who have severe morbidity that is associated with their sepsis diagnosis. When we look at causes of pregnancy-related deaths in the United States, we turn to the CDC's data from 2014 to 2017, and here it lists the causes in ranking of occurrence. You can see that sepsis or infection is the second leading cause of pregnancy-related death in the United States. What's interesting is hemorrhage and hypertension have moved down on this scale, and I think it's because we've been paying such close attention to those and really focusing a lot of our collaborative efforts on that. So I'm hopeful that if we can do the same for sepsis, we can bring down those numbers. As I mentioned, the CDC is certainly tracking this, and they have a program across the country in 14 states called Pregnancy Mortality Surveillance System. And it's a framework for the states that collaborate and look into each maternal death to give them that, like I said, that framework to identify and understand what is happening a little more. California at this present time is not a member of the PMSS. We have what we call a PAMR, a Pregnancy Associated Mortality Review. However, in the spirit of standardization, there is a pilot project that is being funded by CDC in Southern California to see how we can collaborate together to make this process improved and amenable to all states so that we can all be sharing the same information. California has been out in front of a lot of these issues related to maternal morbidity and mortality, and is often looked to as the leader in this, and so it is a great idea for them to come together to refine this system so that all can use it. When you look at the trends in pregnancy-related mortality in the U.S. from the same 1987 through 2017, you can see the trend is not in our favor. This has become the topic of a lot of discussion, some legislation, and I can tell you the 2020 numbers came out and they are even worse. It seems that we are putting a lot of effort into this without really making an impact, so we still have a lot of work to do. We are asked then to also look at this related to race and ethnic backgrounds. We see a very big disparity when we talk about non-Hispanic Black women and compared to non-Hispanic white women. It's almost a 4x increase in the number of maternal deaths. You can see in the non-Hispanic Black it's 41.7 and the non-Hispanic white is 13.4. Hispanic or Latino women is actually the lowest in the United States at 11.6. And just remember that this is not a percentage, but it's a rate, so it's per 100,000 live births. So in order to look at this by race, there's also a lot of work going on to understand where those disparities are and how we can bridge those gaps. I'm sure you've also heard of the Surviving Sepsis campaign. That is a national effort throughout many organizations to kind of thwart the impact of sepsis on our population. And it's really about bundles and tracking data and standardizing the care so that we can have the best outcomes. The Surviving Sepsis campaign has not been generalizable to the pregnant population because it doesn't take into account the physiologic changes of pregnancy. However, the concepts of it are great and are pulled into some of the work that we are doing. So of course there are considerations for pregnant or postpartum women, as we know that their physiology is a little bit different than the general population. What we know with this is that early recognition in a pregnant or postpartum patient can be a challenge because normal physiologic changes of pregnancy often mimic those that are of sepsis, like an elevated heart rate, white blood cell count, increased respiratory rate, etc. Another thought on this is the use of lactic acid. It's kind of a cornerstone in the identification and assessing treatment effectiveness in sepsis, but the utility of lactic acid during labor is questionable. Women with elevated values, though, still deserve some individual attention. So what makes OB patients a little bit different in sepsis identification? Remember, we are showing this same information. This is to the nursing staff, so we wanted everybody to know what each other is learning. So this might probably be a review for you. So what makes OB patients different in sepsis ID is the physiologic changes of pregnancy, as stated earlier, can mimic the signs of sepsis. Elevated heart rate can go up by 10% in the final trimester of pregnancy. Lower blood pressure, that hormonal influence to decrease that systemic vascular resistance, to have a low pressure, high flow circuit to support the growth of the fetus. And then normally towards the end of pregnancy, as women go into labor, they have a higher white blood cell count just to account for the whole process of labor and the inflammation that accompanies it. Labor can impact these even more and significantly raise those lactic acid levels. So some of those hallmark signs or symptoms are a little bit different for us. Well, since we know now that sepsis can be tricky to catch in pregnancy because of the similar symptoms, we should always maintain a high suspicion for sepsis when they start to head down a pathway where they start to have some abnormal vital signs or abnormal findings. We can increase the surveillance of evaluation and vital signs, blood pressure, etc., to be able to recognize and respond quickly to provide the appropriate treatment. So patient risk factors that are associated with maternal sepsis include many of the same risk factors for many other conditions in pregnancy. Specific OB risk factors would be those that may have had an invasive procedure done, or perhaps something left behind, like with retained products of conception, etc. Just kind of raising that awareness for us all. So at SVMH, we have opted to implement the CMQCC, the California Maternal Quality Care Collaborative, two-step process. The California Maternal Quality Care Collaborative has created a toolkit on sepsis, which is very comprehensive and is led by a lot of really smart people. So, like I said, it is a two-step process to try to avoid so many false positives because pregnancy can mimic sepsis. So the first screening step is limited to vital signs that are adjusted for pregnancy and looking at the white blood cell count, preferably within the past 24 hours. The second step utilizes laboratory values and other assessments to confirm end organ injury or damage, dysfunction, etc., that would confirm the diagnosis of sepsis. A little bit more clear, step one. The initial sepsis screen, there's 4 criteria. In order to have a positive sepsis step 1 screen, your patient would need to have 2 of these. An oral temperature less than 36 or greater than 38 Celsius, a heart rate greater than 110 beats per minute. Remember, in SIRS criteria, that is 90. So I would say 99% of our women would rule in on that one. And a respiratory rate greater than 24. That is also different. The white blood cell count is greater than 15,000 or less than 4,000 or greater than 10% bands. The white blood cell count for SIRS criteria is 12,000. So if you have 2 of those criteria, step 1 is a positive screen. What will then happen is the nurse will contact you and ask for more orders to confirm the diagnosis or rule it out. So step 2 confirmation looks at end organ dysfunction such as respiratory, coagulation, liver, cardiovascular, renal, etc., mental status, and lactic acid. We will ask for these laboratory tests, CBC, a coag panel, CMP, and a lactic acid level. Bedside assessment that the nurses will have information on is what is their urinary output, how are they managing their oxygen level, are they having increased work of breathing, what is their pulse ox, and if their mental status is similar, the same, or undergoing some changes, with such as anxiety or disorientation, or difficult to arouse. These are the laboratory values or assessment findings that are that step 2 confirmation. These are specifically spelled out on the checklist as well. So now your patient screens positive with the step 2 with evidence of end organ injury or dysfunction. We would want to prioritize source-directed antibiotics if not already started. If the source is in care, you should give broad spectrum. In the CMQCC toolkit, there is a section specifically devoted to antibiotic selection based on what the suspected source is. If you would like to look at that, please let me know. I can provide that for you. We should increase fluids to 30 mL per kilo within 3 hours of identification if that's not already done. Replete lactic acid, draw blood cultures if not already done. And it is okay to draw blood cultures if they are in antibiotics. If it's been less than 24 hours, we can still gain some information. And if needed, we will call an RRT to escalate care if needed. there is a hospital-wide inpatient sepsis order set that has this information in there. What we need when we are confirming that would be those lab studies that are on the previous slide. So from the Surviving Sepsis campaign in general, some of the key principles are that we need to act quickly upon recognition of sepsis and septic shock, minimize the time to treatment. Sepsis is a medical emergency. Monitor closely for response or lack of response to interventions. If there is a lack of response to what we're doing, we would certainly need to escalate their care. Communicate sepsis during bedside care and handoff. Our nurses have been instructed that that is a key component of information to share during bedside handover or transfer of care, and as well, it's certainly important for physician handover to know where we are, what we've done, and what is anticipated. In obstetrics, we love our golden hours. We have a golden hour for skin to skin after delivery, and there's also a golden hour for antibiotic administration. It's important to have antibiotics started within an hour of the positive step 2 screen. We know that patients who have a delay, for every hour, they have a reduction in their survival by 7.6%. Just a word about lactate levels of pregnancy. We alluded to them a little bit earlier. Lactate levels greater than 4 or a MAP that is sustained less than 65 millimeters of mercury after fluid resuscitation, they really require a quick response and probably an escalation of care. Early fluid resuscitation is key for both of these. We would want to use crystalloids at 30 mLs per kilo and then followed by additional fluids to maintain clinical stability. There was a thought that lactated ringers would not be an appropriate fluid to use for this, but the latest Surviving Sepsis campaign evidence and recommendation says that you can use LR or NS for this. In regards to lactic acid in pregnancy, during labor, it is of little value because every 2 to 3 minutes there is anaerobic metabolism that occurs with contractions and that can contribute to a lactic acid buildup. So I was curious to know how long after labor would this be considered washed from the uterus that you could start to use the lactic acid levels in a more reliable way. I asked Dr. Elliot Mean, who is the medical director for CMQCC, this very question. So he collaborated with some of his MFM colleagues across the state and came back with an opinion that from 2 to 4 hours after delivery, the lactic acid should not be reflective of labor, and that would give you a more reliable indicator of what's going on. But that also would be dependent on how much fluid the patient had received after delivery. Our nurses may do some of these interventions or may be asked to evaluate if their patients will be a fluid responder. Patients can be quickly assessed for the likelihood of their ability to respond to fluid intervention, the 30 mLs per kilo, if they are able to respond with their blood pressure by elevating their legs by 45 degrees. That fluid responder is in a lot of the language when we talk about sepsis. That doesn't mean that if they don't respond, they still don't need the fluids. It just might be an earlier clue that they may need a higher level of care. So what is next? What sepsis has been identified that rapid escalation of care is critical, meaning the antibiotics, the fluid, etc. Early consultation with physicians trained in infectious disease and critical care is also an important part of this. As long as the patients are responding to fluid and antibiotics, etc., they may be appropriate to stay with us. But it certainly would be helpful to have that consultation from others so that we're collaborating and providing a nice, well-rounded plan of care. It may be necessary to transfer a critically ill pregnant patient to a higher level of care. For us, that would probably look like them coming to us on labor and delivery. Not a lot of our ICU folks would probably want a delivering mom in their proximity. So once sepsis is identified, what we're teaching our staff is if your patients show any of these signs once sepsis is identified, that they escalate care immediately and call in our RT. Those would be those that have a sustained MAP, less than 65 millimeters of mercury, their respiratory rate's greater than 25, they exhibit shortness of breath or other work of breathing, abnormal heart rate, bradycardia, tachycardia, etc., mental status changes, or anything that would show us that their peripheral perfusion is off, or perfusion in general. They have cyanosis, their extremities are cold, they have that lacy pattern on their skin with mottling, their urinary output is decreased, or they start to exhibit chest pain. We will call an RRT. Criteria for consideration to transfer your patient to a higher level of care would be those that cannot maintain their blood pressure, those that have a sustained MAP of less than 65 millimeters of mercury after the fluid resuscitation. They may need some invasive hemodynamic monitoring and vasopressors to maintain their adequate blood pressure. Or, of course, if they are not able to maintain their SATs. So if they have persistent hypoxia, less than 92% on room air, they may also need a higher level of care. We're really trying to help our staff understand mean arterial pressure and its application to care. In sepsis, we're really stressing the 65 millimeters of mercury. We know that patients with sepsis who can maintain a MAP greater than 65 millimeters of mercury have improved outcomes. And we understand too that a MAP of greater than 65 is the minimal that it would take to have perfusion of the uterus and the fetus. Because of course the body does not see those as viable organs or vital organs, and so they're going to shunt that away from them to the brain, heart, and kidneys. Just some definitions here for clarification. We share this with our staff as well. So chorioamnionitis or IAI, intraamniotic infection, what those definitions are, and then how they may be different than the CMQCC criteria for sepsis. Remember, the initial screen is 2 of the 4 positives, 4 criteria are positive, and any of evidence of end organ injury. So in managing pregnancy, sepsis as a lone diagnosis does not indicate a need for an immediate delivery, unless you suspect an intraamniotic infection or chorioamnionitis. Then that would indicate delivery. It's no surprise that we have a preterm delivery rate that is higher than the normal population for women with sepsis. That has been found in 29% of the cases with bacteremia. A lot of questions about corticosteroids in relationship to sepsis or suspected sepsis. What I can find in the toolkit and also ACOG is that less than 34 weeks should still be considered to get corticosteroids. And it may be considered if the gestational age is in that other period from 34 and 0.7 weeks to 36 and 6/7 weeks, where a patient who is not sick, we would give a rescue course. If they have received their original course of steroids, it is not recommended to have a rescue course in that second period of time if we suspect sepsis. Just some other considerations for our population consider avoiding neuraxial procedures. The physiologic status of the patient with sepsis is already compromised, and adding the effect of regional anesthesia may potentiate even more effect. But certainly our anesthesia providers are competent to make that decision. It is just a strong consideration. In summary, for what we've learned, prompt recognition and rapid treatment improves outcomes. We want to respond quickly to a MAP less than 65. A positive screen initially is of 2 or more values, and the confirmation of sepsis is with any end organ dysfunction. And it's critical to have early administration of antibiotics, ideally within that first hour. So how will this look specifically for us at SVMH? Well, every hospital is a little bit different, but for us at SVMH, we have decided on a process that hopefully is very clear and simple. We have designed a Meditech assessment screen that incorporates both steps of the sepsis confirmation process, including the first initial sepsis screen and then the confirmation of sepsis evaluation. So when will we perform the evaluation for maternal sepsis? We're going to do this on admission. We're going to do it with every shift assessment and any time we suspect that we may be heading down that path. If our patients have a heart rate greater than 110, they have an increased respiratory rate or increased work of breathing. If they have an increased temperature. My colleague Alyssa Alexander and I felt that a checklist, a paper checklist, might be helpful for our staff to be able to confirm and make sure that we are not missing any steps in our evaluation and treatment of sepsis. This is not part of the medical record. You may see it in your patient's chart as we are working through the sepsis protocol. Some considerations for monitoring our patients other than with lab values, etc., how we are managing them. We're recommending continuous fetal monitoring, continuous pulse oximetry for those with a high suspicion or confirmation of sepsis. Blood pressures frequently, including postpartum, they would increase the frequency of that. Temperature as well, and we would be evaluating our urinary output every hour. And then, of course, if we start to notice any agitation, confusion, or unresponsiveness, we would certainly report that. So time zero is often a critical element when we're talking about sepsis. For OB patients, time zero begins with the confirmation of the second step. So the confirmation of end organ dysfunction is when our timeline starts. However, if we have any suspicion and we have a positive first screen but not a second screen, our nurses have been instructed that they can always increase the frequency of surveillance at any time on their own if they're uncomfortable with what they're seeing with their patient. So thank you very much. If you have any questions about this process, you can contact me or Alyssa Alexander. Alyssa is our staff nurse liaison. She works with me on the house-wide sepsis committee, and she has been instrumental in gathering information and putting this information together. Also, Dr. Kenneth Jones serves with me on the Beta Collaborative for Sepsis, and he can be very helpful as well. Thank you so much. These are our references. So next steps will be to complete the very short post-test and just bring it to the unit and drop it off, and the staff can give it to me. That will also be the confirmation of completion that we share with our medical staff leadership. Thank you very much. I hope you all have a wonderful day.